Start with case 1, which is a 12-year-old girl with history of puberty menorrhagia who presented with fatigue, paleness of body, and history of pica. So I would like to ask our residents, Nikita, if you have this history, what do you think that you will be looking at if you see the CBC?
So, ma'am, I think as there is history of pica and fatigue, paleness of body, so there might be iron deficiency anemia.
Yes, you're right. So this is a patient who's having a lot of bleeding. So puberty menorrhagia it is a sudden bleed. In addition to that, you don't know what the nutritional status of the patient was earlier. So this kind of increased bleeding, especially if there is a poor nutritional status earlier, can cause iron deficiency anemia. And pica is one of the most characteristic histories for iron deficiency anemia. So pica doesn't just mean eating mud or eating paint. It also means eating of ice chips. So remember all this history when you think of pica. So this is the hemogram of the case. Dr. Priyanka, would you like to comment on the hemogram? Okay, Dr. Mintu, can you take the hemogram?
Yes, ma'am. Ma'am, the TLC, it is 5,680, so it is normal. And hemoglobin is like very much reduced, 6.3 grams. And platelet is normal, 2 lakh, 1 lakh, 2 lakh. And RBC is into a lower level, 4.16. It is slightly reduced. And hematocrit, it is markedly reduced. MCV is also reduced, 58.9. MCH is markedly reduced, 15.1. MCHC is also reduced. CM is also reduced. RDW is very high, 21.4. And then, ma'am, then scatter or MPV, that is normal.
Very good. So MPV is good. As regards the DLC, do you think that is normal or abnormal?
For the DLC, ma'am, like neutrophils is majority. Like it is quite like for the DLC, it is normal. I feel like.
Yes. So DLC is absolutely normal. So you have it effectively. What kind of anemia, Dr. Mintu?
Ma'am, it is mostly like the history also suggests a pica, and also the MCV is low, MCH is low, and hemoglobin is low. So it and RDW is very high. So it is going towards a microcytic hypochromic anemia, and we could most probably say that because with the history and with the hemogram, we could most probably think of iron deficiency anemia.
Okay, great. So that is right. That you were talking about. So your microcytic hypochromic anemia point is very well taken. Dr. Ankita, do you want to discuss the flags at the end? These flags here. So I'm enabling the laser pointer. I'll just show you the flags.
Ma'am, it is not visible actually.
These flags. Now can you see it? The black line. So you have an iso plus plus, micro triple plus, FC variability plus plus, hypo triple plus.
Yes, ma'am. Anisocytosis means there is difference in size of RBC.
Yes, very good.
And microcytosis means RBC will be small in size.
Yes. So HC variation means that there is variation in the chromia in the cells, and hypochromia is the flag that is also marked. So if you have intensity, if you look at the intensity, that is the microcytosis and the hypochromia that your machine has analyzed. Okay. Dr. Smita, do you know which series of cell counters does this hemogram come from?
This is a 5-part analyzer because it's mentioned 6-part analyzer. It's mentioned all the different WBC morphology, and it's also given in a comment about the retic. Also, it's given a comment on.
Yes. So this is a 6-part analyzer with an automated retic count. So we have different technologies for cell counters, and you'll read them in the subsequent lectures also. And if you want to teach them something more on this slide.
So next, Dr. Vivek. So most of the findings have been discussed. So we have so far seen a case which history suggestive of anemia and iron deficiency anemia. And the hemogram so far shows an isolated anemia because the WBC count is normal, platelet count is normal. Only anemia is the feature, and as described by your colleagues here, rightly so, microcytic hypochromic anemia. So the MCV is low, the MCH and the MCHC are low. So with this setting, and Madam also pointed out the appropriate flags in this setting, which is anisocytosis, etc. Just any one other parameter which would you like to note in such a scenario with such background, which is again present in this hemogram, which will add on to your diagnosis and let you know about further characterizing the type of anemia.
If we do a Menzel's index, we
Okay.
could find out what kind of anemia we are dealing with. If we do an MCV by the RBC count, we see more than 13, so I would think more likely of iron deficiency anemia.
Okay. So yeah, I will just point out one other parameter here. So
Vivek, what was your Menzel's index that you calculated in this patient?
I calculated the MCV by the RBC count.
Yeah. So what was the value?
So I'm getting around it's 14,
Even
14.5.
use a 4 mil count, 14.5. Okay. So can you come on to what is Dr. Ganesh has highlighted?
For the
so
retic.
yeah. So do you think retic count can give you some additional information with that background? And how do you
Uh,
interpret retic count in this scenario and in general when you are evaluating anemia?
so the retic count is in the normal range,
Okay, you
and
are partly correct. Yeah. So so here the range given is 0.5 to 2.5, and as you said, it is almost in the range. But whenever you are interpreting a retic count, we have to, especially a reticulocyte percentage, you have to interpret in the background of the hemoglobin. Why is that so?
so then we can calculate the corrected retic count.
Yes. So you have to, so the reticulocyte percentage per se does not give you the full information. You have to factor in the correction factor. So the correction factor is for the degree of anemia, and using standard tables, you can correct the percentage of reticulocytes. And also the reticulocyte production index also takes into account not just the corrected factor, but also the maturation factor. Okay. So if you calculate that, what do you think the reticulocyte count will be in corrected reticulocyte count will be in this patient? So let us say it's 2.5 roughly, and the hemoglobin is 6. So what's the corrected reticulocyte count? It's
So
almost
that's
half of
point,
what is
half
expected.
of it. Yeah.
Yeah, so it's in
So
the middle or lower range. And another parameter is the second parameter here, which is highlighted by an arrow. So what is this? Hash retic. So can Dr. Ankita tell me what this is?
So notice that in the report you have hashes percentages, right? Hashes are not just against retic but also against neutros, eos, lymphos, monos. So they give you a clue to what the hash means.
So the hash means absolute number. Okay. So as ma'am mentioned, percentage. Whenever the WBCs are mentioned in the printout, it's either percentage, or it's one is percentage, the second hash is the absolute number. So you have the absolute reticulocyte count, which is 105, which is 1,05,000.
yeah.
So what do you think about this reticulocyte count, Ankita?
So the reticulocyte count is within the normal range, absolute
Yeah.
reticulocyte
So it's
count.
so yeah so we mentioned about so we just went through what is reticulocyte percentage and reticulocyte absolute numbers. We'll come to that in a minute. We'll discuss that in detail, little detail. So what do you think is the importance of reticulocyte count in when you are evaluating a case of anemia? So basically,
So
reticulocyte tells us about the bone marrow reserve, isn't it? Whether the bone marrow is adequately responding to the anemia or not. So, how do you use the terms with respect to bone marrow response and the reticulocyte response? as well as the percentage and number of reticulocytes. Dr. Nikita?
Sir, hypoproliferative anemias and hyperproliferative anemias. When the RBI is less than 2.5, it is hypoproliferative.
Yeah, that's correct. So when the bone marrow is responding appropriately, it is proliferative or hyperproliferative. If it's not, then we use the term hypoproliferative. And the reticulocyte numbers, both percentage and the absolute numbers, gives us a rough idea of how the bone marrow is functioning and whether to put it as hypoproliferative or proliferative, hyperproliferative type of anemias. But you have to remember that this reticulocyte percentage and the numbers are relative. You don't just go by just one number, whether it is within the normal range or outside the normal range. You have to take the whole picture. So for this degree of anemia, we expect, if the bone marrow is responding well, we expect the reticulocyte count to be much higher. But this is either normal or within the lower range of normal, so we may put it up as a hypoproliferative anemia.
At the same time, when we call hypoproliferative anemia, it does not mean that the bone marrows shut down production completely, because your reticulocytes are at least being produced. They are just not in proportion to the anemia. Okay. So we'll move on to the next slide. So what do the CBC findings suggest? I'll ask Dr. Mintu to take this. You have options of iron deficiency anemia, dimorphic, thalassemia trait, and IDA with thalassemia trait. So we'll wait for the replies by the audience, and once our moderators give us the go-ahead, we'll address this question to Mintu if it is not answered by the audience correctly. So do we have the answers to the poll question?
Yes, ma'am. Iron deficiency anemia has been the most
Commonest
That's the only answer. That's the only answer that has been given.
Okay, great. So, Dr. Mintu, would you also agree with that answer, or would you want to consider option 4?
Like mostly the history and the CBC like pointing that is towards the IDA. But like the retic count is not increased. So I would like to consider IDA with thalassemia trait also.
So you are partially correct. You are correct that we would consider IDA with thalassemia trait, but the explanation for that is not correct. So it is not the reticulocyte count. Even an iron deficiency anemia alone, or pure iron deficiency anemia, when that will present, the reticulocyte count or the response from the marrow will not be adequate because it lacks iron. So the cells that are it is not a hyperproliferative anemia. So it is not going to be associated with a raised retic count unless and until the patient is on iron therapy. Okay. That is the only situation where you will get a raised retic count. So there are other clues which tell you that there is thalassemia trait, and we'll just come on to those. So if I have to ask you to interpret the graphs, Dr. Smita, what will you interpret them as? Say the graph which says RBC VHC, say this particular graph. So, Ankita? So if you don't want to field the question, at least tell us no so that we're not waiting.
No, ma'am.
No. Anybody else wants to take it? Feel free to just unmute yourselves and go on.
Ma'am, it's basically going that is towards a microcytic hypochromia and like a right angle like that. So which usually that is seen in the scatogram, that is usually seen in the iron deficiency. Like it is having a microcytic picture and also hypochromic picture. Both are there.
Yes, so you have microcytosis and hypochromia. If you look at the same graphs, the histograms, you realize that the RBC volume histogram shows you a leftward shift, which indicates microcytosis, and the chromia also is reduced here. The HC graph here that talks about the chromia. So you know that the RBC histogram and for the chromia is showing you a leftward shift as well. So a microcytic hypochromic anemia. And this is the peroxidase channel. So this is where your WBCs are. So this is the ADVIA counter, cell counter by Siemens. it functions on the for the WBC counting, it functions on the peroxidase channel. So therefore, you've got neutrophils in magenta, you've got eosinophils here. Then this green cells are the monocytes, and the blue cells here, they are the lymphocytes. Okay. So with that, again, we'll have this question. So what is the methodology for measuring RBC parameters on the ADVIA series of analyzers? We understand that every one of us has a different 5 or a 6-part cell counter. So it becomes difficult to remember all of them, but knowing basic principles of all the cell counters is helpful. So therefore, this is the poll question. So the moderators, if you can let us know what is the commonest answer.
So when the while the audience is answering the poll questions, Vivek, what cell counter do you have in your institution? So as ma'am mentioned, each institution has their own cell counters, and the principle is different. And it's important to know the principle behind each cell counter. So Vivek, Dr. Vivek,
Six-part analyzer.
which make or company?
So it's the Sysmex.
What is the name?
Sysmex. Oh, okay.
Sysmex.
Which series? Any idea? Good.
I think it's
Okay, that's fine.
I'm not sure exactly.
Okay. Dr. Smita, what cell counter do you have in your institution?
So even we have the Sysmex only.
Sysmex.
So when you talk about the equipment, do you remember the name of the equipment? So Sysmex comes up with many cell counters. So knowing which equipment you have is also important. So XE series, XN series, something else.
Yeah. It was an XN series.
It's an XN. Okay.
XN series,
So
yeah.
Ankita,
Ma'am, I think Sysmex, but I don't remember that.
That's fine. So anybody have Siemens? This one is from ADVIA. So Siemens ADVIA platforms at your institution. Okay, what about Dr. Mintu? Which platform you have? Which cell counter?
Ma'am, sir, it is a 7-part machine we do have.
Yeah. It's a Beckman Coulter, or is it?
But
so you have a DXH 800 with you?
I'm not sure.
So moderators, if you can help us with the answer, the commonest answer that you've got.
Yes, ma'am. The commonest answer is impedance, and followed by the third one, which is flow cytometry with low and high angle scatter.
Okay. So ADVIA series of cell counters actually do not use flow cytometry alone and impedance alone for the generating this particular graph. So what they use is an RBC sphering followed by flow cytometry using a low and high angle scatter, which means that every RBC that goes through the machine is converted to a sphere. It doesn't matter what original shape did the RBC have. So this is the RBC method. You have, if you look at the cells that are walking in, there are all different kinds of cells, be it a sickle or an acantho or an echino, but what comes out is a sphere. So whatever the size or whatever the shape of the cell is, the ADVIA series of analyzer converts it to a sphere. So, and then it does the flow cytometry. So this is a unique feature of this particular analyzer. I wish you were saying something.
With respect to the most common answer, impedance. So, I mean, with ADVIA, Siemens is an exception. So most of the cell counters use impedance method quite frequently. So an impedance method is mainly used for particle counting. So ADVIA is an exception rather in this. So it uses other methods like what ma'am mentioned, RBC spearing, and then flow cytometry based methods. Basically, it's an optical scatter methods using light scatter collection at different angles, low and high angles.
So usually the cell counter that you would have would generate a RBC histogram. So that is what gets generated if you're using the impedance based methods and calculating from there. Herein, once the cell is sphered, the instrument assesses the low and the high angle scatter, prepares this scatterogram, and eventually prepares a MIMAP. So this is all that your equipment is doing. Eventually that leads to these three parameters that we saw. So this is a 9-grid histogram which tells you where your cells are lying, whether they are microcytic or they are macrocytic, and what is the chromia of these cells. So we'll ask another poll question. What do you think will be the morphology of RBCs in the case that is shown?
So while the audience is answering the question, Dr. Mintu, can you give us a number, a value for the lines 1, 2, 3, and 4? Do you think they have a specific?
Yes, they do have like a specific, that is how that is we differentiate it to the microcytic and hypochromia. So for the microcytic like 80 to 100 and the hypochromia that is around like a 26, that is to that I guess so. I'm not sure of it.
Yeah, that's a good guess. Dr. Vivek?
So I'm laughing because we have put you through the grind. So we've given you a cell counter that you're not familiar with. So that is the reason why I smiled. I think we've been difficult with you. So don't worry about it. And cell counter is a gradual and a continuous learning process. So don't limit yourselves to just the printouts. Walk up to your lab, see the cell counters, see the screens that they have, so that you're familiar with at least the one you have with you. Dr. Vivek.
Yeah,
So
could it be standard?
Would it be standard deviation?
Yeah.
So this is, again, as I told you, it's a computer generated graph. So it is the internal algorithm that the machine applies. So it is not a standard deviation based algorithm, which you characteristically see with RDWST. So that is not what we're looking at, because this is again not an impedance based method.
So yeah, so on the x-axis is basically a representation of the hemoglobin concentration, what is shown as Hc in picograms. So the line shown as 3 is and the 4 are at 28 and 41, if I remember right. And the lines 1 and 2 basically represent the RBC volume, which are basically 60 to 120. So this is basically not to expect values from you, but just to give you an idea that this algorithms have some basis behind them, and if you can understand what basis the algorithm is made, it will be helpful to understand the histograms and plots better.
So moderators, Dr. Bindu, what's the most...
Normocytic normochromic is the
Yes.
So the audience is absolutely right. So this is a normocytic normochromic red cell. This is where you expect your normal red cells to be. Now, where would you expect macrocytes to lie is the next poll question. So remember that the volume, sir explained something in the last slide, the volume on the Y and hypochromia on the x-axis. So what is the commonest answer that we've got?
It's the between line 3 and 4 and above 2, followed by 1, which is above line 2.
Okay, so third is the most common answer. What we are expecting is above line 2. Why not between line 3 and 4? Because we did not ask you whether macrocytes were normochromic or whether there was a dimorphic anemia and the macrocytes were also hypochromic. So anything above line 2 is a macrocyte. The rest of it we'll get to know once we look at the chromia part. So if this instrument, as Dr. Ganesh was saying, the range that it puts it at is between 60 to 120 femtoliters and between 28 gram per deciliter to 41 gram per deciliter for the chromium. And the graphs that gets generated, the graphs that are generated is that if you have iron deficiency, you have hypochromia as well as microcytosis. Haltrate, usually you have a reduction in the volume. Megaloblastic anemia, you have macrocytes. While in myelodysplastic syndrome, some of them can be hypochromic, so they can move to the left. Anything that is hyperchromic, which is represented by sickle cells or spherocytes, even schistocytes, they will move to the right. So this is just the brief about the cell counter.
So just to add one point, just to recall. So as we can see in the left plot, that the calculation is based on the light scatter at low and high angle, whereas impedance is commonly used in other platforms.
So in this case, you have cells that are overlapping. So you have cells both in this area where you have pure iron deficiency, you have cells that are moving here as well, which are only microcytic but not hypochromic. So this patient, in addition to that, if you remember, had a hemoglobin of around 6, while the RBC count was 4.16 million. So Mintu, when she highlighted, she said that RBCs are just about marginally reduced. So if you look at it, This is actually relative erythrocytosis. So at a hemoglobin of 6, your expected RBC count would range somewhere between 2.3 to 3 million. Instead of that, it is sitting well above 4 million, which means that there is relative erythrocytosis along with the microcytic hypochromic anemia. And in India, iron deficiency anemia with thalassemia trait is a very common problem that we face. So we come on to the smear. Dr. Ankita, would you like to take the smear?
Yes, ma'am.
Go on, can you describe it?
Ma'am, as
So
we
this is
can
a low
see that,
magnification. Yeah, yes, please go ahead.
am I audible?
You're audible. Go ahead, please.
Ma'am, as we can see that there are different RBC shapes and size in this sphere. So we can say that there is anisocytosis and poikilocytosis.
Very good. So if you are given a little higher power view, does anything else jump out at you?
Yes, ma'am.
So this is a slightly higher magnification. This is the 200 magnification. So this is 20x lens. So does anything else jump out at you?
So that's fine. So this is a low magnification. So yeah, you mentioned about some RBC changes. So what else can we see in at this magnification? So in not just for this case, for any case. So we
So
have
we
a.
can see target cells or pencil cells.
Very good. So you're picking up target cells and pencil cells as the additional anomalies. So you're absolutely right. But what Ganesh sir was asking was that in a general case, not just specific to this case, low power magnification, what else will you assess?
So you will have a fair idea of the WBCs, right?
Yes, yes.
In case you could see a few WBCs which appear. They
Yes,
don't
sir.
appear to
I
be
can see
common.
that. Yes,
Yeah, and about do you see platelets at this magnification?
yes, yes, sir. Yes, sir. So it's not visible, but
Okay, but you have a rough idea of what it is. That's fine. So we'll go to
yes, sir.
still higher magnification.
So in these views, you can make out that you have cells that you correctly picked up as target cells and as pencil cells. In addition to that, would you like to describe the general picture of the RBCs, Dr. Smita?
In this slide, you can see some lymphocytes, and you can see most of the RBCs are smaller than the small lymphocytes, so you can say it is microcytic. And you can see the central
Very
pallor of it, the central pallor is more than 2/3, so you can say there is a hypochromia.
yes,
Other
very good.
pencil cells and teardrop cells you are picking also, there is a anisopoikilocytosis you can mention also.
Very good. So when you said the lymphocyte, what part of the lymphocyte are you referring to compare the size itself?
The nucleus of the small lymphocyte.
Very good. So in the nucleus of a small mature lymphocyte, that is what you use. So in addition to that, if I look at this photograph on the left, the third photograph, I see the neutrophil. Is that showing something? So this
The
particular
third,
neutrophil.
there appears to be a little hypersegmentation, I believe.
Appears to be a little hypersegmented. So remember that when you read causes of hypersegmented neutrophils, we always talk about vitamin B12 and folate deficiency or a classical megaloblastic anemia as a cause. But even if you go back and read deeply, you will see two other causes. That will be iron deficiency anemia as well as uremia. Okay? So we have to remember that hypersegmented neutrophils are not specific to B12 and folate. In the right context, when the MCV is elevated, they do help, but you can have other conditions in which you see hypersegmented neutrophils as well. So are the platelets very well visible in this power?
I think it is enough to make out it is adequate in number.
Yes. So you are still able to see enough platelets to know that the platelet count is adequate. Okay. So this is the higher power view, effectively essentially the same findings. You have hypochromia, you have microcytosis, and when you have to compare the sizes as correctly told by the participants, we need to look at the nucleus of a small mature lymphocyte. So now what is the final diagnosis that we have? We have an iron deficiency anemia. According to me, we have a concomitant thalassemia trait. You may have your doubts on that, and I can understand that. So what are the further investigations that you would like to do? Let us ask Vivek.
I want to do an iron studies, iron profile
So what
study,
are iron? What is
and
included in the iron profile?
the serum iron, the total
Yes,
iron binding capacity.
very good.
Then we have of the ferritin.
Yes.
Yeah.
So one
And
more
the
test.
transferrin saturation.
Very good. So transferrin saturation. So these are the iron profile that you would do.
So what would you expect? What are the results that you're expecting in this case, given that we are thinking of iron deficiency anemia? Dr. Vivek?
The serum iron would be low.
Mm-hmm.
And
What about PIBC? Total iron
sorry,
binding capacity. What about the other
PIBs,
parameters?
they would be they would go the opposite direction. They would be increased.
Yeah.
Yes,
Okay.
very good. What about ferritin and person transferrin saturation?
Could be normal or transferrin saturation.
Okay.
I think, I'm not sure.
So if you have enough iron in the body, then iron circulates with transferrin, right? So that is what we are
Yeah.
measuring. And what percentage of the transferrin is bound by iron? So if your serum iron values are low, then in this situation, very likely, why is the iron low? Because the transferrin, you have a deficiency of iron. So the transferrin that is present in the peripheral blood, not a lot of it was saturated with iron. If it was, then the iron would have been able to be, could have been delivered to the tissues, right? So actually we expect a low transferrin saturation in addition to a low ferritin.
Okay.
So of these, Dr. Smita, which one is the parameter that is the earliest indicator of an iron deficiency, even when, say, a patient does not have anemia? TIBC, okay. Which parameter reflects iron stores?
Ferritin.
Ferritin. So ferritin is a reflector of the iron stores. So first iron stores get depleted, then the anemia sets in. So ferritin is the first to be reduced. So iron deficiency anemia, you said, you did say this correctly. What does the hemogram suggest? You remember that there was a possibility of coexisting thalassemia trait. So Ankita, would you like to do any additional test to look at if this possibility is correct or not?
For thalassemia, we can do Nestrov test.
Okay, Nestrov test is a screening test for thalassemia trait, right? So it is a field test which you want to do in when you are screening many patients and you don't have the luxury of running all their samples through the specific testing mechanisms. So any other test?
HPLC can be done.
Right. So hemoglobin HPLC is the test that you would like to do in this patient concomitantly.
So these were the results of serum iron profile. So Dr. Mintu, can you just quickly interpret the test results?
Yes, sir. Serum iron is markedly reduced, 34, and total iron bind capacity is increased. Transferrin saturation is 8%, that is markedly reduced, and serum ferritin is also markedly reduced.
Yeah, good. So what's your interpretation? So it fits with our diagnosis of iron deficiency anemia, right?
Yes, sir.
So what are the problems when we are looking at serum ferritin alone? So does it always help us, or can there be conditions where serum ferritin can mislead?
Yes, sir. It can even in infection that is sometimes it can there is a slight increase it can let us in serum ferritin level. There is
So
a
it's a marker of stored iron. So even inflammatory states can increase serum ferritin. So interpreting that alone can sometimes lead to confusion. So you have to take the whole picture into account. So Dr. Ankita, would you like to do a bone marrow examination in this patient for iron stores?
Yes, sir. We can do bone marrow examination.
Would you like to do? Or you are happy with the investigation so far?
If you want to do, why do you want to do a bone marrow?
For confirmation of the diagnosis for iron stores.
So with this iron profile and with the CBC findings that you have, you are, what percentage surety do you have that this patient has an iron deficiency anemia? So nearly 100%, right? You have a low ferritin, you have low iron, you have high TIBC. So you definitely know that you're dealing with an iron deficiency anemia. So this is one indication where you do not do bone marrows. There is no point of doing bone marrows to say that bone marrow is the confirmatory iron store finding. So that is why we'll do a marrow, because we want to see that the bone marrow lacks iron store. So that is not an indication for doing the bone marrow. So iron deficiency anemias per se alone is not an indication for doing bone marrows.
So yeah, as ma'am mentioned, so this question was asked just to make you understand and to make things sure that bone marrow examination is not required. It's not required for a diagnosis of a classical iron deficiency anemia. Though quote unquote bone marrow iron stores are quote unquote the gold standard, books mention them as gold standard for iron stores, but they're not required in a routine setting in a classical case of iron deficiency anemia. The tests from the peripheral blood, including the hemogram values, the serum iron profile, or with the clinical picture, are enough to make a confident diagnosis of IDA in almost all cases.
Okay, so an HPLC was also done for this case. So the poll question is, what is the diagnosis based on the HPLC findings?
So in the meantime, Dr. Smita, so which is the platform for analyzing hemoglobin protein in your lab? Do you use HPLC or an electrophoresis?
Actually, it is not available. We do it outside.
Okay. Okay. So Dr. Vivek, what about you?
It's the you do it by HPLC. You do by HPLC.
You do it by HPLC. Okay. So moderators, do we have the commonest answer?
Actually, ma'am, there are only okay. Now few answers have come up. The most common now is the third option, which is heterozygous B thalassemia.
Right. So this is the correct answer. And the next poll question is, you have to identify the techniques in A and B in the correct order. So neither of these are HPLCs. The 4 options are given. So Dr. Mintu, what about
Yes,
you? What method do you have for analysis of different hemoglobins?
Then HPLC only we are having.
HPLC.
Hence,
So has any one of the participants seen these graphs earlier at their institutes or otherwise?
Yes.
capillary zone electrophoresis.
Yes, absolutely right. The left one is the capillary zone electrophoresis. So moderators, what is the answer that we've got?
Actually, only 2 of them have answered, ma'am. One of them is capillary zone electrophoresis and alkali electrophoresis in the option 1. And the other one is
Right.
densitometric, the third option, which is densitometric scan of alkali electrophoresis and
So
capillary.
option 1 is the right answer. So we have capillary zone electrophoresis, where dependent on the charge of the hemoglobins migrate, and we have different zones. And based on which zone the hemoglobin falls in, it is designated, and there is libraries available to which of the zones will have what hemoglobins that will fall in there. The right picture is from the standard alkali electrophoresis, which was used before the HPLC and the capillary zone electrophoresis came up. Now it is only used as a second technique, if at all, in different labs. So now we'll move on to case 2.
So case 2, basically it's 2 cases side by side, just to compare and contrast the findings. So the first one is a 2-year male with anemia since 6 months of age, history of blood transfusion since 6 months of age, and once in 2 to 3 months is the frequency of blood transfusion is receiving, and with splenomegaly about 3 centimeters below the costal margin. The case 2B, it's a 22-year-old male with anemia since 2 years of age with intermittent blood transfusions. Total is around 8 to 10 so far, that is 22 years of age. And for the last 1 year, he's having increasing requirement. And because of this, he underwent abdominal procedure for an expected symptomatic relief. So coming to the case 2A, so we start from here. We'll ask Dr. Nikita, can you just interpret the findings of case 2A and 2B?
Yes.
Just the main findings, and then you can summarize what you're seeing in this.
Based on the history, both the cases, they are requiring multiple blood transfusions since birth. So something inherited is the probability.
Yeah.
And splenomegaly is present in the 2A case, which is
Yes.
progressing towards hemolysis.
Okay. So what are the other causes of splenomegaly here, apart from hemolysis is one? So that's when we'll come to that later. So what about case 2B?
Case 2B,
So Nikita, we accept that both cases are congenital and
yes.
very likely anemia occurring very early in life. If you
Yes.
had to contrast the phenotype of case 2A and 2B, is there a difference in the phenotype?
Yes. As there is increased transfusion requirement in the last 1 year in the case of 2B. So,
Right.
followed by
What about the
abdominal.
Yeah. So what about the transfusion frequency? The first case, that is case 2A, has
First
transfusion once in every 2 to 3 months, whereas
Yes.
the case
2B.
yes, once in 2 to 3 months, whereas case 2B has total of only 8 to 10 transfusions so far. So which one is receiving more frequent and which one is less frequent transfusions?
Is more frequent. That is transfusion dependent. More of that.
Yes.
And
So
2B
transfusion
is,
dependent thalassemia is case 2A and case 2B how would you refer to that?
it is also requiring transfusion, but as the transfusion requirement is increased in the last 1 year, so some.
So I think you're getting confused with the last line. Besides that, if you look at the first 3 lines, onset of
Intermittent,
anemia at 2 years, the
yes.
transfusions, then what is the phenotype that you're looking at? It is a non-transfusion dependent thalassemia. So when we talk about transfusion dependent thalassemia, it means that the patient cannot make enough blood to last even for a couple of months or 6 months or a year on his own. So which means that once every 2 months, the frequency of transfusion for a small child maybe once every 2 to 3 months. As the person would become older, the frequency will increase to once a month. While the case 2B has required only 8 to 10 transfusions in 21 years, which means that when there is a active, so he's able to possibly maintain his hemoglobin between 8 or 9. So he continues to live in that compensated state. His bone marrow is able to compensate till that much, but whenever there would be something that causes an increased demand at that time, he would require transfusion. So this is a non-transfusion dependent thalassemia.
So you mentioned, Dr. Ankita, can you just summarize the hemogram findings of 2A and 2B? You can just mention the important parameters and then give a summary of what you're seeing. Dr. Mintu,
Yes, sir.
Yes,
can you
sir.
take this?
Yes, sir.
Yes, sir.
So in the 2A, it is like hemogram. That is, if you are saying that hemoglobin is 9 grams, that is with it is like reduced. That is for according to the age. But in 2B, that is it is markedly reduced. That is 4.4, which is markedly reduced. And coming that is
Yeah.
to the TLC, that is it was like a normal. That is for the 2A, and for the 2B case, that is it is very much increased. That is it is like 1,97,000. And coming to the RBC also, like in both of them, it has been reduced, but a little bit more reduced, that is in 2A. MCV also, like in MCV, 2B, MCH, and MCHC, that is, it is reduced in 2A, but comparatively that is to the 2B, that is, it is markedly reduced in 2B. And RDW also, it has been that is markedly increased, that is in 2B. And the platelet also, like it is
So the
decreased.
slide hasn't moved, so.
Yes.
Yeah. Oh,
Can you see the screen now? So my screen shows two cases, hemogram of two cases, 2A and 2B.
No,
That
sir.
is
So we can't
hemogram is
we
not.
can't see that.
so we're still seeing the
You can't
history.
see the hemogram.
Okay, so let us try doing the screen share again.
Yes.
Are you now able to see the hemogram?
The slide again
Until-
from case 2 to history.
No, ma'am.
Case 2 history.
Okay,
Yes. Ah,
Yes,
now,
ma'am.
yes.
Yes, ma'am.
You have to go to the slideshow, ma'am.
okay.
Or not yet.
Wait, we'll have to share the screen again because I had to put it in the slideshow mode and then share with you. So now I hope that you have the right screen.
Yes, ma'am.
Yes, ma'am.
So Mintu has described that both the cases have anemia. One case a little more severe and the case 2A less severe. What do you think, Mintu, is the cause of having a MCV of 81 on the left side?
MCV, it is not much reduced. That is like if
For a
you
2-year-old, this is a normal MCV. So for a 2-year-old, remember that there are pediatric ranges. So if you have a small child of 1 or 2 years or till about 6 years of life, you would have RBCs which are slightly smaller in size than the adult. So you have to remember about pediatric reference ranges. So here this MCV is absolutely not.
So why do you think, Dr. Minto, is the platelet count low, 80,000? Do you think
yes.
it's the true platelet count, or can we give some explanation for this, given the history?
Actually, the history that is there is splenomegaly and like a history of recurrent blood transfusion is there, and
Yeah.
moreover in the hemogram that as we can see also like it has been like raised also, so that can be hypersplenism can be also be a cause that is of the platelet that is low, and
Yeah. So yeah. So as ma'am mentioned, MCVs you have to. It's an age-specific parameter, so it look as per the age. And second, these patients are on frequent transfusions, so the RBC parameters may not be native to the patient. It's basically reflecting the transfused blood. So you have to keep that also in mind. So in the case 2B, we had severe anemia, and it is microcytic. Platelet count is normal, but you had increase in WBCs. The WBCs are nearly about 2 lakhs. So what do you think is happening? Any idea?
um, so there is a sports splenectomy, so mainly that is abdominal surgery. So it might be that is because of the sports splenectomy only. So like more of NRBCs that is it is coming. So the because of that, that is the WBC has been that is abnormally, that it is the red that is in the machine as abnormally like increased. So it is like we have to correct like uncorrected, that it has to be corrected. The WBCs has to be.
So thank you, Mintu. Vivek, since you're familiar with the cell counter here, this is the Sysmex series of cell counter. So you usually get NRBCs separately, and there is the NRBC percentage that this equipment is giving. So in this case, that percentage is 0.0. Do you think the equipment is correct? Okay, so we'll soon come to this. So you have to identify the population marked by the arrow. And since we have very few audience members participating, let us go and ask Smita. So Smita, what is the population marked by the arrow on both the WDF and the WNR graphs?
It is a lymphocyte population.
It is the lymphocyte population according to you. Vivek, you agree?
think the lymphocytes are there in blue.
As in the machine is interpreting it as a lymphocyte type.
Machine is interpreting it as a lymphocyte, okay, but you don't see the graphs there. Here, do you see something in the WNR? In the WNR channel, there's a very fat cluster that is being formed here.
With some, some.
So Minto said that there should be some nucleated RBCs here, right?
Yes, ma'am.
So nucleated RBCs are what cause this cluster on the WNR channel. Normally the machine is able to separate it from the leukocytes, but here the number of NRBCs was so much that the counter got absolutely confused. It could not place the clusters anywhere. So therefore, if you see, the only red population that is identified correctly is it has colored. Everything else is gray because it just wasn't able to make out anything. So these were all nucleated red cells.
So we'll come to the, so before going to the peripheral blood film, just a few words on the hemogram and the histograms. So what does WNR stand for, Dr. Ankita? So we have two histograms here. One is WNR and one is WDF. So what do they stand for? What do we expect in this plots? Ankita, do you have a Sysmex in your institution?
Yes, sir. Yes, sir.
Yeah. Can you just take a guess? So WNR stands for white cells and nucleated red cells counter. So where you have specific areas for these cells. So let us say so this one, as ma'am mentioned, is one area, and this is another area. So you have the WBCs put together here, and the nucleated red cells are here. So because the differentiation is so difficult in this case, they have not been able to separate them. And what does the WDF histogram stands for, Dr. Vivek?
Sorry?
So what does this WDF histogram plot tell us? What does the WDF stand for, and what are the information we get from this histogram?
The difference.
So basically, it's the yes, that's right. So that is the white cell differential count histogram, where you can visualize the different white cells. So white cells and the nucleated mast cells. So you have specific areas here. So you have one area here and another area here usually, and one area here and this one here. So what does this plot tell us? What's the population which usually lies in this area?
So this is the eosinophils.
Yeah. So what is the population here? This one.
So Vivek, you started that lymphocytes are being counted. So this is the area where lymphocytes are there.
And you have monocytes here and the neutrophils here. So NRBCs usually come to the left side and below the lymphocytes. Okay. So we move on to the next, move on to the other features. So we have two peripheral smear findings here to compare and contrast both the cases. So Dr. Mintu, can you just tell us what are your findings in this?
So in the 2A, that is, we can see that there is a anisopoikilocytosis is there along with that, and microcytes are there, hypochromia is there. There are some elliptical cells are also seen, and we can also that is see there are neutrophils and nucleated NRBC, one NRB nucleated RBC is there, and
yes.
And
so this is one odd. Yeah. Go on.
Then 2B, that is comparing that with that, there is also anisopoikilocytosis there, but many NRBCs that is like as compared that is to 2A, that is there are many NRBCs are there.
Yeah. So there are too many NRBCs, isn't it?
Yes.
And both of them have reduced RBC density. And again, so this is higher magnification here just to show the NRBC, and you have a lot of microcytic hypochromic cells, target cells, and there is variation in the shape of the cells also. You have cells like this here, and you have a lot of microcytes, target cells, etc. Okay, and this is just to
show you that in case 2B, there is an outpouring of the nucleated RBCs. So if you have to count that per 100 WBCs, you have actually more than 200 nucleated red cells. So the count is markedly high. And in this case, do you see some inclusion here in this cell?
Yes, sir. Yes, ma'am.
So what is that inclusion?
It could be basophilic stippling, or there is one that is then it could be Havel-Jolly bodies also.
So this is a cell that appears to have both basophilic stippling as well as an Havel-Jolly body. So which is the third kind of inclusion that you can see on the peripheral that you can sometimes see?
Papen.
So the Pappenheimer bodies. So Ankita, what are Pappenheimer bodies made of? So Priyanka has joined. So Vivek, what are Pappenheimer bodies made of?
Ma'am, iron
These are
containing.
yes, so they are iron containing. So that is the Pappenheimer body. So again, so peripheral blood film case 2B, you can again see the anisopoikilocytosis. Now this cell here on the left shows you a very nice Havel-Jolly body, right?
so what are Havel-Jolly bodies, Dr. Nikita? What do they reflect?
They are seen most commonly after splenectomy.
Yeah.
So are these nuclear remnants or are these ribosomal RNA remnants?
Or are these iron granules? So they are nuclear remnants, essentially. So they can be seen in states, not just splenectomy, but when the spleen is also not functioning properly in hyposplenic states.
So one more thing and an unrelated thing. Ankita, can you identify these?
Which one, ma'am?
The ones highlighted by this arrow here, by the circle here, and now by the arrow. So these two cells, the WBCs.
So what lineage cells are they? Are they granulocytic cells? Are they lymphocytes? Are they monocytes?
I think
There's no cell that has been highlighted. Actually, that is not.
No change in this.
Okay, no change in the slide again.
We can't see
Yes.
anything, ma'am.
So are you able to see the screen with
Yes,
two
ma'am.
peripheral blood films?
Yes, sir. Its screen is there. The arrow for the Pappenheimer body was there, but otherwise there's no other.
No other arrow. Okay.
Just give us a minute. We'll reshare.
We're resharing the screen. Now, are you able to see the two peripheral smears?
Yes, ma'am.
Yes.
Okay. So we are again taking the felt tip pointer. So this was the cell where we tried to show you the Havel-Jolly body. And this was the question which, now are you able to see annotations or no?
Yes, ma'am.
Yes,
Now the
yes.
annotations are.
So Ankita, I was asking about these two WBCs. What do you think these two WBCs are?
So one on the right, one's on the right. There are two cells sort of sticking to each other.
Ma'am, I think they are lymphocytes.
Very good. So they are lymphocytes. Any particular character to these lymphocytes?
Granules are there.
Dr. Vivek? Yes. Mintu, there are granules and these appear to be large granular lymphocytes. So the point that I'm trying to make is you don't use these lymphocytes to assess the cell size because they are slightly larger than the small mature lymphocytes also. And that is the reason why we only refer to the small mature lymphocytes when we are looking at the assessment of the cell size. So how do you explain the elevated TLC in case 2B? Vivek, now what is your answer?
Interference with the nucleated RBCs.
Yes, so interference with the nucleated RBCs. Our modern cell counters are becoming very smart, and most of the times they give us a correct nucleated RBC count, and they also give you a corrected WBC count straight away. So you don't have to do the calculations. However, in this case, when there is an overwhelming outpouring of the nucleated RBCs, that does cause interference. So if we ask you what abdominal surgery, I think Mintu's referred to splenectomy in this case, right?
Yeah.
We
Yes,
already have the diagnosis of 2A with the clinical phenotype. We're looking at possibly transfusion dependent thalassemia. 2B, we are looking at NTDT. So further things you will get to know once you do the further testing. So what additional investigations will you do? So let us ask Smita. Smita, what do you think will be the additional investigations that you like to do?
Go for an HPLC to
Very good.
further look at the
Okay. So an HPLC. Do you expect any interference with transfusions?
yes, ma'am.
So what is the timeline that you would want? So case 2, say, has a hemoglobin of 9 gram per deciliter, and if you know that he's received a transfusion a week earlier, would you prefer that time to collect the sample, or would you like to tell the family or do something else? Nikita?
we will wait for the RBC lifespan to
So very frequently in thalassemias, you cannot wait for the complete RBC lifespan because the patient is at a critical hemoglobin value where you will need to transfuse. So effectively, we try to give as long a gap as possible, or we at least take a sample before the next transfusion. So when the patient comes for the next transfusion, just before that, we can collect the sample and do an HPLC on that sample. In addition to that, he's a 2-year-old boy. So 2-year-old male child obviously cannot come to the hospital on their own. So Nikita, anything else that you can do now? I've given you a clue.
Any further investigation?
Yeah, so let us say, so we are talking about HPLC per se. So, and you are right, HPLC is the next step and useful investigation, but again, it has its limitations. It cannot be done when you have frequent transfusion. So, one way is, as ma'am mentioned, take a pre-transfusion sample. So, even if that is going to be difficult in many patients because they are getting transfused very frequently. So what else can you do with respect to HPLC that can help you support the diagnosis, give you an indirect clue about your diagnosis? So it's an inherited disease, right?
Parents has to be
Parents.
Yes. So you
genetic.
can do you can test the parents, or you can do the genetic, whichever is easier. So for a 2-year-old child, getting access to parents is very easy. So parents only will bring the child very likely. So you test for the parents. So for case 2B, as you correctly identified, that the surgery that was performed was a splenectomy, and these were the clues to presence of splenectomy. And a splenectomy can lead to the presence of Howell-Jolly bodies, NRBCs, thrombocytosis, and target cells. The diagnosis, as we've already discussed, for case 2B, it's a Thal intermedia or NTDT post-splenectomy status, but the patient is still undergoing a very rapid decrease in the hemoglobin. So the splenectomy has not been helpful, even though it has been effective, and that you know with the number of Howell-Jolly bodies that you have. Additional investigations, as we've mentioned, we'll do the HPLC. In addition to that, the family screening, the parental HPLC becomes very useful, especially in patients who are heavily transfused or transfusion dependent thalassemias. In addition to that, if there are subsequent pregnancies that a family is planning, an antenatal screening for subsequent pregnancy and counseling for that becomes again important to prevent birth of further thalassemia affected babies. So what is the pathognomic finding post-splenectomy in the peripheral blood film? Dr. Ankita, would you like to take this question?
Yes, ma'am.
Nucleated.
Uh, I think it's B.
You said D for delta,
No, ma'am.
right? You said B, pathog.
I think
So all 4 options you will see in a post-splenectomy smear. So what is the characteristic or the pathognomic finding is what we are asking you. So target cells, you yourself described even in the earlier case of IDA with PTT, there were a few target cells. So that is not specific for splenectomy. Even in case 2A, non-splenectomized, you have target cells.
Nucleated red cells you can see in even hemolytic anemias like HS, etc., where the bone marrow is throwing in more nucleated red cells into the peripheral blood. And thrombocytosis with anisocytosis and large players can be seen in many different conditions, including infections, iron deficiency, when the marrow is responding to a bleed, etc. So, and Howell Jolly bodies, as ma'am mentioned earlier, it basically is an indicator of splenic dysfunction. No? So when there is no spleen or when the spleen is not functioning properly, you see Howell Jolly bodies.
Okay, so well, first we asked you what do you expect to find, and now we are asking you what will you not expect to find. So moderators, do we have any answers from the audience coming in, or should we
Yes,
ask?
ma'am. Yes, ma'am. They are coming in, and the previous one they correctly answered as Howell bodies.
Very
Most of
good.
them had.
Okay, what about this one? Now we have something.
Yeah, they're starting to answer now. Most common answers B.
Very good. And the earlier poll question was a very big clue because the three options, the other three options are there. So it is a macrocytic anemia that you don't expect. So with that, I think after the first case, I forgot to invite Dr. Murli to give comments. So Dr. Murli, if you would like to comment on both the cases.
Hope Murli has reached home by now. Mumbai traffic can be crazy.
Okay, so I don't think we have Murli with us right now. So we'll move on to case 3. So the case 3 is titled I Vote Left. What about you, Dr. Ganesh?
So case 3 is a 35-year-old male with splenomegaly and history of 4 PRBC transfusions till date. So only 4 till date, 35 years old. So here we have the hemogram findings of this gentleman. So Dr. Mintu, can you take us through the hemogram and just
Yes.
summarize, highlight the important points?
Yes, sir. So WBC is 12,750. That is a slightly increase, and RBC is like in the normal range. Hemoglobin it is 11.4. That is it is slightly reduced, and HC hematocrit it is 32.6. It is normal range, and MCV MCH MCV MCH it is reduced. MCHC it is in the normal range, and the platelet is in the higher range, like it would be normal only for like 23,000, slightly increased. RDW CV it has been increased 18.1, and MPV it is normal.
Okay, that's fine. So
any comment on the reticulocytes?
Reticulocyte it is 5.11, so that is in the it's increased.
So this is definitely an increase. Even if you correct for the hematocrit, it will still be an increase in the reticulocyte count. In this case, your machine has been able to identify the nucleated RBCs here correctly. So it has also told you that there are some nucleated RBCs, and the TLC that it is giving you is the corrected TLC.
So it is. So to summarize, it's basically a isolated anemia, microcytic anemia. Mild elevation in the with elevated reticulocyte count, right?
Yes, sir.
And leukocytosis and thrombocytosis as well. So TLC is slightly elevated, platelet count is slightly elevated, both slight elevations. Okay.
So, Dr. Vivek, can you just mention the peripheral blood findings?
Can you tell me again?
Dr. Vivek, can you tell us about the peripheral smear findings in this?
Yeah, the peripheral smear findings. So the RBCs mainly look that of a normocytic normochromic. There are a few microcytes as well, and few elliptocytes. I can see some occasional sickle cells, target cells as well.
Okay.
And,
Yeah. So what about these cells? Do you think the hypochromia
So Vivek, the first thing that hits you about the smear, you may not be able to appreciate whether the cells are normal in size or larger in size or smaller in size, but can you see the chromia of the cells? Does it appear to be normochromic or does it appear to be hypochromic?
It appears to be hypochromic.
Yeah.
A large number of cells, they are hypochromic, and occasional target cells are also there. Here, maybe here, and then we have a couple of cells here. And you mentioned some sickle-shaped cells, right?
Yeah.
Okay.
Okay, Vivek, one more finding I would like to highlight on this. So if you can still see the annotations, do you see something here? In this RBC, do you see a purple dot?
Yeah.
So what do you think the purple dot is? Is it a platelet or are we looking at something more?
The color is slightly different, isn't it? So here you have the platelets, the larger one, normal one. Here, this one.
Any other thing that this can be?
So anything within the RBC, which we discussed earlier?
So this particular RBC, and if it is the RBC, Hubble Jolly. So this is a Hubble Jolly body. You have a patient who's got some sickle-shaped cells, who's got target cells, who's got hypochromia, occasional Hubble Jolly, and maybe occasional NRBC as well. So in addition to that, if you have a look at the smear, the sickle cells that you have highlighted, are all the sickles having a very sharp edge or are they appearing to be slightly bloated in the center?
Slightly bloated in the center.
Slightly, so have a look at this one. It appears to be slightly bloated in the center and the periphery it seems to be thinning. So what are these cells called? These cells are called boat-shaped cells. Remember the conventional boats look like this. So these cells end up looking like this. So sometimes when you don't have a lot of sickling happening, these cells are the only clue to the diagnosis of a sickle cell anemia. So Vivek, you've identified sickle cells, you've identified hypochromia, and you've identified the target cells and occasional Hubble Jolly body. So what do you think does this patient have?
So usually in the sickle cell, we won't get hypochromasia.
Yeah, very good. So sickle cell what? Sickle cell anemia, sickle cell trait?
No, in sickle cell anemia.
Ma'am, the slides are stuck in the previous smear.
We are on the previous smear only. So we are again on the same smear picture. So I'm just asking Vivek questions now.
Okay.
So Dr. Smita, do you expect iron deficiency commonly in sickle cell anemia?
In sickle cell and iron deficiency
Yeah.
possibility here. Yes, sir.
Possible. Is it common? Is it
well, as
unusual?
In sickle cell, if patients can be normocytic or in some cases they are microcytic also.
Microcytic, they are usually normocytic. So this patient seems to have a microcytic anemia. The MCV is also low, and we do see a lot of hypochromic cells in the peripheral smear, and probably there is microcytosis as well. So Dr. Mintu, what do you think about this picture, microcytic picture in a case of sickle cell?
Yes, it could be like it could be like with the beta, like a thalassemia trait also, like a compound heterozygous condition, like whether because if it is sickle cell anemia, it could be more sickling has to be that the sickle cells has to be there, but it is not seen. Like board-shaped cells are there, and one or two sickle cells are seen, and more of target cells and microcytic hypochromic picture is also there. So I feel like there might be that is too, like a compound heterozygous condition with the sickle cell and the thalassemia.
Okay, very good, Dr. Mintu.
So yeah, so the idea is to tell you that classically sickle cells and other hemolytic anemias, there is iron overload. So iron deficiency is usually not a feature, though sometimes you can see that in the Indian population. But when you see a microhypo population in hemolytic anemias like sickle cell, you think of an associated hemoglobinopathy like a thalassemia, co-inherited thalassemia. So you think of compound heterozygous states.
Okay. So now we're showing you pictures from two tests. So this is test A, okay, and if you see, this is like a wet mount prep, and this is
Ma'am,
another
the
test.
slide is stuck.
Ma'am, we can't see anything.
No, the smears are
Slides have
the
got
same
stuck.
smear.
Okay, it is on the same smear again.
Yes, ma'am.
Sorry, we apologize.
We apologize. It seems that there are a lot of technical glitches that we are facing today. So let us try the screen share again. So now, has the slide changed?
Yes, ma'am.
Okay. So this was test A that was performed. So what do you think is test A? Dr. Nikita?
Ma'am, it is sickling test.
Very good. Sickling test.
Yes.
And okay, we'll just come back to sickling test in a minute, Nikita. Nikita, what do you think is this test? And we've already shown you one image like this earlier.
This is HPLC graph.
This
So
is the
hemoglobin
graph.
HPLC, right? So
Yes.
HPLC is a technical protein. So yeah, so it's understood that it's hemoglobin HPLC, but it's good to mention the full name. Okay.
So we are looking at the hemoglobin HPLC. So you've already given us the tests. So say we have the sickling test and the hemoglobin HPLC. So Nikita, what reducing agent do you use for doing the sickling test? Do you know that? So we have
Yes.
two. We have sodium metabisulfite or sodium dithionite that can
In
be
our
used.
college, we use sodium metabisulfite 2%.
2% sodium metabisulfite. That is a common reagent that is used to perform the sickling test. And the key part in a sickling test is that you need to cover slip it and seal the cover slips to create hypoxia. Right? And when you're doing a sickling test, you have to observe for at least overnight, at least preferably to 24 hours, because some cases where the amount of sickle hemoglobin is low may take longer times to sickle. Okay, so these preps that I'm showing you on the right, they are actually from the dithionite prep. So you see these very long tails coming out. So dithionite causes a slight different morphology for sickling with these long projections that appear in the red cells. So now, do you know what is the minimum level of sickle hemoglobin that will cause that will lead to a positive sickling test? In other words, what is the sensitivity of this screening test for sickle?
Ma'am, even one sickle test in the smear, if it is present, then it is.
Yes, that is the interpretation of the test. That even if you find a few sickle cells in the entire prep, that also tells you that there is sickle hemoglobin, and the amount obviously may be lower. But I'm asking you that what percentage of the total hemoglobin should be HbS for this test to be positive?
So these patients can have transfusions sometimes, and their HbF levels may be elevated. So that will alter the HbS, the baseline HbS levels in these patients. So ma'am is asking, what's the HbS level at which you can expect a sickling test to be positive, and below which it can be falsely negative?
Okay. So that is about 15 to 20%. So if your sickle hemoglobin is less than 15%, this test may not be positive at all, even with 24 hours of incubation. Okay, so the diagnosis in this case that we suspected was a sickle beta thalassemia, and you've all highlighted the changes that are present in this case, which suggests the possibility of a concomitant or a compound heterozygous state for sickle and beta thalassemia vis-a-vis a homozygous sickle. So why not a sickle cell anemia? So you had clues here. You have the microcytic hypochromic nature of the anemia, and on the HPLC, Mintu, would you like to point out what is the parameter that tilts it toward compound heterozygous state for sickle beta?
Yes, ma'am. In the S window, that is, we could say that the retention time is 4.4, so it is comes under S window, and the area is 79.3%, so that is very high. Very high, and A2 level is 4.6, and HbF level it is 14.6. So it could be like a homozygous condition. That is, if it is HbS level, that is, it is more than that is 50. But since A2 and F level, that is also there. So and with the my PBF that is smear, that is liquid, that is likely in conclusion that it could be a heterozygous condition with the sickle cell and beta.
Yeah.
Cobalt
So
heterozygous.
highlighted the point of A2 very well. The A2 is elevated. So HbF levels up to this may be seen in the Indian population, even with homozygous sickle patients, because India has the Arab Indian phenotype of sickle, where the HbF levels, they are higher. So that is one. So it is the A2 that gives you the most frequent clue. Usually in a case of sickle cell beta, very likely the HbF levels, they go above 20%. In this case, the HbF was not that markedly elevated as we would have expected. And the other finding where you said that because it is 4.4, it is in S window. So the instrument actually has predefined windows. So they come with the CD-ROM card. So S window is anything say between 4.3 to 4.6. Here it is at 4.4. So the instrument is trying to place it in the S window. So you're right that this is hemoglobin S, but the reason for the S window is slightly different. So you have these findings because of which you know that you're dealing with sickle beta thalassemia. Any other clinical clues? If you remember the history, this was a 35-year-old male with splenomegaly. Vivek, is it likely that a sickle cell?
No,
Yeah,
yeah,
go on.
sickle cell usually have autosplenectomy, but the fact
Yes,
that
so
there
sickle
is
cell anemia. Yes, very good. So if the 35-year-old male has got a large spleen, then that is very likely that this is not a homozygous sickle. So these are the HPLC findings. So in a sickle trait patient, you have S window that usually ranges between 35 to 40%. In this patient, it is slightly lower than that because of possibility of concomitant alpha-thal or an iron deficiency. However, as Dr. Ganesh described, homozygous sickles and compound heterozygous sickle betas, you don't expect concomitant iron deficiency in these patients. So this is a patient who's homozygous sickle, and if you have a look, the F, it is slightly elevated. A2 is less than 4%, and your S window is dramatically elevated. So to compare and contrast our patient had raised A2 values, so it was 4.6%, which makes it a compound heterozygous state for sickle beta thalassemia. So this is HB electrophoresis, where dependent on the charge, the alkali, and so the left one is the alkali electrophoresis and the right one is the acid electrophoresis. So if you remember your alkali electrophoresis, you have this particular band here in the middle. That is the band where you can have sickle, T, as well as ORA, Q India just a little below this. So this is the band that I'm referring to. So to separate sickle and D, we do the alkali acid electrophoresis. So which of the following in the husband would not warrant an antenatal CVS examination in a pregnant female with sickle cell disease?
So basically, this question is to make us understand how does sickle cell genotype interacts with other associated genotypes to worsen or ameliorate the condition. So basically, the mother is a sickle cell disease, and then we have this four potential conditions where, if present in the spouse, may or may not be beneficial or may or may not be detrimental.
So moderators, do we have some answers? Okay. So Dr. Mintu, what do you think is the condition which won't matter?
I think SPD Punjab, it might be, I'm not sure.
You're not sure. Dr. Vivek?
I mean, I think HBD Punjab.
Okay. Dr. Nikita?
Even I think it is HBD Punjab.
So what is common to A, B, and D? What makes C different from A, B, and D? So A, B, and D, all three are beta chain associated, isn't it?
The poll answers.
Yeah.
Usually
B is the most common, ma'am.
common.
D is the most common.
B.
B for ball.
B.
B.
Okay. So
Followed
remember
by
that the
D.
pregnancy followed by C. So I'm glad that at least somebody said C. So B is a significant sickling disorder, potential for a significant sickling disorder, because the mother will give one sickle allele to the child. If the spouse's sickle cell trait allele comes in, so if the spouse's sickle allele also comes in, then you have a possibility of homozygous sickle. So it is, as Dr. Ganesh pointed out, in all the other three, your beta chain is affected dramatically. So in beta thalassemia trait, you have absence or lack or marked reduction in the amount. So only sickle hemoglobin will be produced. Sickle cell trait, I will just explain. And ST Punjab is also a significant sickling disorder.
So yeah, so you're thinking I can understand that hemoglobin D Punjab in heterozygous state or even homozygous state is not symptomatic, whereas when it combines with sickle, it worsens the sickling, so it becomes a symptomatic sickling disorder. So it's important to test for hemoglobin test to keep that in mind and advise the parents accordingly.
So, okay, so this is one of the smears from a sickle cell anemia patient. That is a sickle cell disease, the classical sickle cell disease. And you can see a dramatic increase in the number of sickle cells in classical sickle cells. And if you have a look, you've got frequent Howell Jolly bodies in this smear. So now this particular patient that I just showed you underwent a procedure following which a HPHPLC was repeated. This is the same baseline HPLC that we've shown you for a homozygous sickle, and the HPLC to the right is the HPLC that we are referring to now. So if you are referring to this particular HPLC, if you see the amount of sickle hemoglobin has dramatically reduced from 83.9 to just about 8.3%. So what do you think is the procedure that this patient underwent into?
Splenectomy.
Okay, so splenectomy would lead to a lesser reduction in the fall of the hemoglobin, but do you think it will alter the RBC constitution?
The sickle cells are produced from the bone marrow.
Right, so it the RBC constitution.
Bone marrow transplantation. Anything simpler?
So bone marrow transplantation, say if had happened in this patient and the donor was a normal donor without any sickle hemoglobin,